Okay. So, for those of you that don't know me, Jennifer Torres, I'm a PGY5 second-year fellow. And the reason why I decided to, is this recording?
Yes.
Okay. And the reason why I decided to do this topic is because I have a kind of a rare case at the health department, and basically it inspired me to look more into details about the new recommendations for HIV testing. And this is the case. This is a 41-year-old female from Brazil who recently moved to the United States and comes to our clinic in order to establish care. She reports that she was diagnosed back in 2005, after she presented to her PCP with flu-like symptoms and extensive cervical lymphadenopathy. She was initiated on lamivudine, tenofovir, atazanavir with ritonavir. The only lab work that we have available from Brazil was since 2007, which basically show undetectable viral load with a total CD4 count that ranged between 400 to 500. She does have a history of arthritis, which was unclear to me whether it was secondary to RA, but based on the history, it's consistent with RA. She's been on chronic low-dose of prednisone and sulfasalazine, and she said that she was diagnosed about in 2007. In addition, she also has a family history of lupus. So when she comes to our clinic, as part of the intake form, basically they do a 4th generation test, and she had repeatedly reactive tests, which means that they repeat the test for the first time is reactive, they do a second time, and it was reactive. However, the antibody test, the confirmatory tests for 1 and 2 were negative. And obviously she had undetectable viral load, so that was going to be negative anyway. So keep that case in mind, and we'll discuss at the end of the presentation, we'll discuss this case again. So how many types of HIV we have? We have HIV-1, HIV-2. HIV-2 is endemic to West Africa, Europe, Portugal, has been seen in South Asia and India. There have been less than 100 cases reported in the United States. And HIV-2 infection doesn't prevent, if you are infected with HIV-2, it doesn't mean that you cannot get HIV-1. In fact, you can get co-infection with both. And the importance of knowing whether your patient is co-infected with HIV-2 is basically because HIV-2 is not sensitive to NNRTIs due to this Y188L. It also can have this Q151M mutation, which confers multi-drug resistance to the NRTIs. So that's the reason why you want to know whether your patient is co-infected with HIV-2. And actually, the initial screening tests that were used in the United States did not include HIV-2 testing because it's very low and very rare. This is more common in West Africa. Okay? So now talking about HIV-1, HIV-1 is divided in 4 groups. Group M basically stands for major or main. Group O is outlier. Group N stands for not M, not O. And Group P was identified in 2009 in a Cameroonian woman. And this group is closely related to the gorilla simian immunodeficiency virus. Okay? So now the major group, the Group M, is the more common and basically had different subtypes. You have 9 different subtypes, and the reason why I highlighted the B is because when you talk about the different subtypes that HIV has, you talk about the subtype B and the non-subtype B. The subtype B is actually more common in North and South America, but however, worldwide, the non-subtype B is more common. Also, you can have different subtypes within the same individual, so you can have A and B, and that's what the CRF stands for. Now this is a phylogenetic tree which basically shows you the different groups, HIV-2 and the HIV-1, and then within the HIV-1 group you can see the different subtypes, and then you can see the group N and so on, and how it's related to the simian immunodeficiency virus. So basically this is an illustration of the different proteins that the virus has, and it's basically comparing the HIV-1 with the HIV-2, and as you can see, some of the proteins change are kind of different. So obviously in the Western blot you will not you can have some cross-reactivity and basically have a Western blot that will show some bands if you have HIV-2, and it can show like in a determinate Western blot, but I will show you that later. So basically this is an HIV-1, and these are the different proteins, the envelope proteins that are used in binding and fusion, the accessory proteins, the structure and assembly, and the ones that are used for replication and maturation. So this is very simple. I'm just gonna the ELISA test is the one that we use for screening. For a screening test you want a very high sensitive test, and basically what the ELISA does is just detect antibody to an antigen. Okay, so this is an example of direct ELISA. Basically you provide the antigens in the wells, and you then apply the patient serum, and these antibodies, if the patient has the antibody, is gonna attach to the antigen. Then you add another antibody that's gonna bind to the antibody, human antibody, and this has a enzyme that when you add the substrate, when it catalyzes, it basically shows you whether there's a positive test or not. So now the sandwich technique is the one that is being used for the 3rd and 4th generation screening test, and basically it's kind of the similar scenario. The only thing is that when you add the conjugate, it's actually an antigen that is bind to an enzyme, and this, when you add the substrate, it basically lights up. So why right there all confirmatory tests? Because actually in the new algorithm and recommendations we are not using Western blot anymore, and in fact in my patient we wanted to order a Western blot, and basically we have to contact the state lab in order to see whether there was any lab that is performing these Western blots. So the Western blot, as I mentioned before, you can detect subtype B, non-subtype B, and actually group O. I will talk a little bit about that later. And this is basically an example of a Western blot. In the left side you have the HIV negative, and then you have the HIV-2, and you can see that there's a band there, and probably that test will be read as an indeterminate test. But then you can see the other subtypes, and then the subtype B. And that's basically a positive Western blot showing all the bands. Actually, the Western blot detects IgG, and we'll talk about that later. Also, there was another confirmatory test, the indirect fluorescent antibody, which basically, once it binds to the antigen, it lights up, and here is an example of it. So the NAT, I was confused about the term NAT. I was like, is PCR a NAT? So basically NAT is nucleic acid amplification test, and you can detect RNA or DNA. Shortens the window period, is highly sensitive and specific, and there are different methods. The one that we are more familiar with is the PCR. There's also branch DNA, but I have never seen that one being used, at least at the health department. You also have the transcription-mediated amplification, and then the nucleic acid sequence-based amplification test. So this actually, I don't know if you guys can see down there, but this is a table from the Mandels, and basically it gives you all the screening tests that we have available. and it actually tells you what we are detecting with the test. Are we talking about IgM? Are we detecting IgG? Are we detecting P24 antigen? And actually gives you a little bit of description when do you use this kind of test. And it tells you also whether there is a version that is FDA approved or not, and whether the test also detects HIV too. So, and you can see down in the lower part, there's actually a home collection or a home testing that you can perform at home, but I'm not going to talk about that. But just you to know. But the ones that we're going to be talking is the combination HIV P24 antigen and HIV antibody, which basically detects the antibody and the P24 antigen, and it's a combination assay. So, talking a little bit about, so once you have day 0 infection, there is actually gonna be the first thing that can detect some virus in the system is basically a nucleic acid test, and that doesn't happen until 10 days later after infection. Okay, so basically at 30 days you will expect that the viral load is gonna be high enough that any test is gonna be able to detect that. Now the HIV P24 antigen is will be able to detect that around 15 days after infection with a peak of 30 days. And then the HIV antibody is the last thing that happens, and basically that's usually like 20 to 25 days later after the infection. So so basically these have like different names. This period in particular, once you have the infection and then you are able to detect some DNA of the virus or RNA of the virus, we call this the eclipse period. Then followed by the acute HIV infection, where you can actually detect RNA of the virus, and then the established HIV infection, which basically you're chronically infected at that point. So the first generation screening test, you were able to detect antibodies at day 50. With the second generation, we did a little bit better, and we will be able to detect. We were able to detect antibodies at like 30 to 40 days after the infection. The third generation did better, and now the fourth generation with the P24, we're able to almost detect around 15 days or 20 days after the infection. And again, the nucleic acid test, you will be able to detect 10 days after the infection. So basically the seroconversion window is basically based on the specific immunoassay that you are using. And as you can see, once we increase in generations, the seroconversion window gets shorter. So the other thing is that when you read about the fourth generation test, there has been some rare cases of a second window period, and it has been reported when the antibody begins to appear, during which the antigen binds to the antibody and inhibits the detection by the assay. And that Mandel's talks a little bit about it, and actually when you read the new recommendation guidelines, it talks about it a little bit too. And so the evolution of HIV immunoassay technology. So basically the first generation, the way it used to work was you had you grow the virus in a cell culture, and basically you use those antigens to detect the antibody. And the immunoassays were done as indirect immunoassay format. With the second generation, they did better, and they actually, instead of using the HIV virus grown in cultures, they actually did synthetic peptides. And that basically what it did was eliminate the cross-reactivity with cellular proteins. So therefore increasing the sensitivity of the test. So also the second generation was designed, it had specific antigenic epitopes that improved the sensitivity for group O and the HIV 2. Now, the third generation continues to use the synthetic peptide. It also allows the detection of IgM and IgG, so that's why the window period you can detect earlier before during early seroconversion. With the fourth generation, it's basically a third generation test, but you added the P24 antigen, and that's the term combo assay. It does not distinguish between antibody reactivity from the antigen reactivity. So why the updated recommendations? So basically, FDA approval of improved HIV assays. There was false negative or indeterminate results early in the course of HIV infection. They acknowledged that the HIV transmission is higher with acute and early infection, and there is clinical benefit from antiretroviral treatment, in addition of mixed classification of HIV-2 infections as HIV-1 by the HIV-1 Western blot. So the HIV Western blot and HIV immunofluorescence assay is not that was previously recommended as a confirmatory test, is no longer part of the recommended algorithm. So this was studies that they have done looking at the two FDA approved fourth generation tests, and basically has like a 99.94% sensitivity, and the other one says 100% sensitivity in all those patients. So this is the algorithm. So basically what it detects is, do I have an HIV-1 antibody, do I have an HIV-2 antibody, or HIV-1 P24 antigen. It doesn't really tells me whether which one of those is actually active. So if it's negative, basically I don't detect any of those. But if it's positive, then I have to do a HIV-1, HIV-2 antibody differentiation immunoassay. And this is basically what you do to do this antibody differentiation. If you have HIV-1 positive, then done, HIV-1 infection. And if you have the 2, then done, you have the HIV-2 infection. If you have both, then you should be thinking that you have co-infection or one of them is positive. And the problem, and this is my case with my patient, HIV-1 negative indeterminate or indeterminate, HIV-2 negative. And basically you then do a nucleic acid test, which in this case is a PCR. And if it's positive, then you're done, because then you have an acute HIV infection. But if it's negative, then it means that you don't have an HIV infection. So going back to my case, a 41-year-old female that reports that she was diagnosed back in 2005. Basically, we don't have any data from before, and based on these tests, basically she's HIV negative. So that's where we're like, okay, what we do next? So so that's the question. What's the best explanation of this patient? Did the patient was misdiagnosed with HIV, so it's okay to stop all antiretrovirals and discharge her from the clinic? Patient was cured from HIV. I need more information, including Western blot and viral load at diagnosis if available. Or the patient lab work is consistent with second window period, which is not. So there's some exceptions. No lab test is perfect, and the fourth generation test, even though that is good in detecting early HIV, is not completely perfect. So there are some exceptions to this. Late in the course of HIV infection, in the presence of profound immune deficiency, antibodies level may decline, but at that point you will expect that you will have detectable RNA. So you will expect that your nucleic acid will be positive. In rare cases, HIV infection may proceed in the absence of detectable serologic marker, but such patients have been characterized by rapid disease progression with CD4 lymphopenia, which is not the case of our patient because she had her CD4 count was in the range of 400 to 500. So this is the one that kind of explains more. Early introduction of antiretroviral therapy may delay development of full antibody response to HIV infection. therapy may decrease the relative levels of anti-HIV antibodies and may affect the detection by certain diagnostic platforms. So we asked the patient to see if she was able to get more information from Brazil. And basically, in fact, she was treated as acute HIV. When she presented, in January with the lymphadenopathy and the symptoms, and her initial test was negative. But then in February, her viral load, I think, was like 500,000. So they start her on treatment right away, and she actually had a detectable viral load at that point. So basically, I look a few studies. This study is a HIV-1 antigen specific and non-specific B cell response are sensitive to a combination of antiretroviral therapy. So this is a study that had two cohorts group. The first one, they basically screened 19 naive treatment patients. 16 were selected for the study. 4 patients were acutely infected, and their definition of acutely infected was less than 90 days. And then 6 patients were chronically infected, and 6 of the other patients were not selected for the trial. And basically, the trial consisted of 4 active drugs, including cidovudine, lamivudine, abacavir, and an experimental PI. What they did with these patients, basically 18 out of 19, they checked the baseline immunoglobulin antibody secreting cells. And then basically this is what it shows. At baseline, most of them have very elevated antibody secreting cells, but as they started on treatment, you see that there is a decline on these cells. However, in the first patient, in the number 902, that is kind of high, that patient stopped treatment. So obviously it's expected with viremia you're going to have detectable immunoglobulins. Then the second cohort, basically they selected 13 patients, and these patients were started on cidovudine, lamivudine, and this other PI, boosted PI. 3 of the patients were acutely infected, and 10 were chronically infected. Each individual has been treated between 16 to 36 weeks before immunologic studies, and all had undetectable viral load at the time of circulating antibody secreting cells were analyzed. So I don't know if you guys can see, but basically it looks kind of confusing, but in the left side, in the top, you can see the chronic infected patients, and in the lower part you can see the acute ones. They basically it had the duration of infection. They have the CD4 before therapy and after therapy. They also have the viral load at diagnosis, and then the viral load when they check these immunoglobulins. And you can see the viral load was on everybody was undetectable. They measured the immunoglobulin G and the immunoglobulin, and you can see that as they started on treatment, the immunoglobulin actually in fact decreased. And it also happened with the antibodies to glycoprotein 120 and to P24 as well. So very interesting here. These patients actually, the first one on top, actually seroreversed. He was positive before, and then his P24 became negative, and the other one actually never seroconverted. And we are talking about a chronic infected patient. The next one, the following one, also seroreversed. He converted at some point, but he seroreversed. And then in the acute one, you can see that some of them never seroconverted, and some of them never developed anti-P24. So the results was that basically there was a marked decline in immunoglobulin antibody secreting cells in acute and chronically infected people within few weeks after therapy. The anti-glycoprotein 120, specific for immunoglobulin antibody secreting cells, usually fail to mature in acutely infected individuals who were promptly treated with antiretroviral therapy. So the conclusion was that the HIV-1 infection drives B-cell hyperactivity and that this polyclonal activation is rapidly responsive to decrease in viral replication caused by combination antiretroviral therapy. So this is another study, basically, and the title is Incomplete HIV Type 1 Antibody Evolution and Seroreversion in Acutely Infected Individuals Treated with Early Antiretroviral Therapy. Basically, they look at 150 patients with symptomatic acute or early onset HIV infection that were treated with antiretroviral, and they were observed prospectively. They basically follow them with serial ELISA test and Western blot testing until they fully evolved. HIV-1 antibody was documented. The B lymphocyte function was assessed by measuring IgG response to CMV. In particular, in this was actually from Clinical Infectious Disease. They talk about these three particular patients, and the first one was a 30-year-old male with HIV, acute HIV. His viral load was greater than 500,000. Day 12 after presentation, his Western blot was reactive with glycoprotein 160 bound and weekly P24. Viral load became undetectable 69 days after the antiretroviral. After 11 months of therapy, HIV, ELISA, and Western blot were negative. The second patient, after 38 months of antiretroviral therapy, ELISA was positive. However, the Western blot seroreversed to negative. And the patient 3, a follow-up at 40 months, showed positive ELISA but indeterminate Western blot. So the hypothesis is that maturation and affinity to the virus-specific antibodies requires time, which may be avoided with early therapy and rapid virologic suppression in patients with acute HIV-1 infection. Early treatment may result in the loss of HIV-specific antibodies, and seroreversion may be secondary to waning antibody response due to prolonged virologic suppression, irrespective of when the treatment is initiated. So in conclusion, incomplete evolution of HIV-1 antibody response and or seroreversion can occur in patients with acute HIV infection treated with early conventional combination antiretroviral therapy. So this, I think, is the best explanation for my patient. I mean, we actually don't look at screening tests once a patient have HIV, we actually don't look back to see whether the patient seroconverts, seroreverse. We actually don't look at this. We continue treatment. So in my patient, we stopped antiretroviral therapy for 2 weeks. She continues to be suppressed, and we actually checked. I put her back on treatment when I had the results, and we checked Western blot, but the Western blot is not bad yet. So I assume that maybe it's gonna be negative. So we'll see. So when you are at the VA, in the different hospital, it's kind of confusing. What should I order in terms of screening tests? And basically, the VA has a very good explanation, or when you order the lab test. And if I have to choose, I will select this one, the HIV-1 to Antigen antibody combo, and actually tells you what they are detecting. It detects group M and group O. It doesn't detect group N or P. And basically what they do is they do the test. If it's positive, they repeat the test again. And then they follow that by another ELISA, which ELISA just detects antibody to see whether it's HIV-1 or HIV-2. At that point, you should be ordering a nucleic acid test, in this case, PCR. They also have this HIV antibody antigen panel, which I think is the same thing, but it doesn't give you so much explanation of the test, but I assume that is the same test. And then in Moffitt, I will vote for the HIV antibody antigen combo. I'm assuming that they're using the 4th generation test. And here at TGH, it's a little bit more confusing because it says HIV antigen combo. I mean, it should say antibody antigen combo test. And I don't know what the HIV antibody screen means, because I don't know if they're just screening for antibodies or they're actually detecting. So it's very confusing, because then in that case I would choose HIV.
I can depend you, or either two tests are going to give you the same thing. The combo test. They just revert to the combo test.
Okay. The HIV.
They're the same test. It was the old test, but there isn't one. They're all going to just do the fourth generation test. The combo. It's going to be combo. They're both going to be the combo. You know what I'm trying to say? They need to fix that.
So that's the end.